Welcome. My name is Dr. Jeff Grove. My pronouns are he, him, and it's a pleasure to be your moderator for today's session. I'm a third-generation osteopathic physician, board certified in family medicine. I have been in private practice for nearly 30 years in Florida. As a member of the LGBTQ community who was in search of resources during my education and throughout my professional career, I believe this CME training is a welcome part of the learning cycle for current and future physicians. And it is a continuation of the Foundation's mission to help you be the best healthcare professional you can be. Our goal with this session is to provide best practices that will assist you to develop an inclusive, safe, and welcoming environment for your LGBTQ+ patients, and in turn, improve healthcare outcomes for this population under your care. An estimated 7 out of 10 LGBTQ patients have experienced negative care. Because of this, they often avoid healthcare settings, which leads to fewer doctor visits and poorer health outcomes. We will share ways to help patients connect with you so that you can alleviate their concern, allowing them to seek routine treatment without the fear of judgment or subpar care. Being here today is the first step in making your LGBTQIA patients and their allies feel welcome and affirmed. Quality healthcare is not necessarily noting a difference in biology or behavior between LGBT people, but in the challenges and stigmas that make LGBT people vulnerable to illness. A major difficulty in understanding LGBT health is a lack of data. The small amount of data that does exist shows deep disparities for LGBTQ+ people and significant gaps in understanding between patients and their providers. To bridge that gap, at the end of this session, you should be able to, first, describe several unique healthcare needs of LGBTQ+ patients and some common barriers to receiving care. Second, to demonstrate respectful and affirming language with patients, regardless of gender, identity, or expression and sexual orientation. Third, to identify changes needed to increase access to care within your practice. And finally, to implement personal and organizational changes to make LGBTQ+ patients feel welcomed. To help us achieve these learning objectives today, I'm pleased to introduce our panelists, a distinguished group of individuals representing the osteopathic profession. Today with us, we have Nicole Wadsworth, DO, Matthew Else, DO, and Austin Bolay, OMS 3.
Well, thank you, Dr. Grove, for the opportunity to participate in this distinguished panel today. And thank you to the American Osteopathic Foundation for making this part of their Cultural Competency series for OMED 2022. My name is Nicole Wadsworth. I currently am the Dean at New York Institute of Technology, College of Osteopathic Medicine. I am trained as an emergency physician, and I've spent a good part of my career both practicing medicine and in academia. I identify as a cisgender lesbian, and in my role as Dean of a COM, I'm focused upon how to both provide the welcoming and belonging community in the medical education setting, simultaneously provide the needed curriculum for our students to provide culturally competent, inclusive, and excellent care to their patients. I feel incredibly fortunate that the feeling of being welcomed and that I belonged to the osteopathic community has been present since I was a medical student, and I want to continue to build upon that culture in medical education. The strategy to accomplish this goal of an inclusive culture, from my perspective, is with education, patience, and compassion.
Hello, my name is Matthew Else. I am a family physician in Tulsa, Oklahoma. I currently practice in a private practice and have multiple organizations that I work for around northeastern Oklahoma to help provide services to the underserved communities. And one of those communities is the LGBTQIA+ community. So it's a huge honor to be here, and it really means a lot that the AOF and the OOA are taking a moment to recognize the need for better healthcare in this area.
Hi, everyone. I'm student Dr. Austin Bolay. I'm an osteopathic medical student here in Louisiana. I am now the inaugural recipient of the Jeffrey Grove DO LGBTQ Pride Scholarship. And I want to start out by saying to thank Dr. Grove for initiating this scholarship, because to me, it's going to be a beacon that's going to just hopefully instill validation and encourage members of this community to pursue medicine, which, you know, like a drop in the water, is going to cause an improved representation within this healthcare industry, which will then hopefully improve cultural competency of all healthcare providers, and then hopefully begin the process of mending the ever-growing distrust and divide that exists between the LGBTQ community and healthcare members. Beyond that, I think my biggest contribution to this discussion is my lived experience. I'm still in my training to become a physician, but I have well over 15 years of being a cisgender gay man and being a leader within my community. I was a bartender for over 10 years. And so I believe that is my largest contribution to this, hopefully to provide a more intimate perspective of the issues that now plague this community.
Can you talk specifically about what difficulties LGBTQ individuals may have in accessing healthcare? And what are some examples of the disparities that exist?
So that's a great question. And thinking about barriers for the LGBTQIA population, unfortunately, there are multiple. Some are geographic in nature, meaning patients can't find care in their area, more so finding competent providers in their area. And sometimes the requirement to travel long distances can really impede the ability to access care. I would say one of the biggest concerns, though, is discrimination. And there are multiple surveys that have measured this, and it is rampant within the LGBTQIA population as far as discrimination, simply refusal of care, or because of discrimination or a history of it, patients don't seek care any longer. Additionally, some of the most vulnerable individuals in this particular population, the transgendered individuals who are people of color, face the most severe discrimination. Additionally, insurance is either lacking or inadequate, which contributes to it, as well as general biases in the thinking process of providers.
Please do.
Yes, so I think Dr. Wadsworth hit the nail on the head. Just to kind of add some perspective, I've had the illustrious opportunity to have to move constantly to do my training. And I can't tell you how much anxiety and fear goes into having to find and establish with a healthcare provider in a new town, particularly here in the South. You know, getting healthcare is stressful enough, but now I have to worry about, is this person going to, you know, shame me? Am I going to have to deal with the prejudice that comes along with it? Am I going to walk in and they're automatically just going to assume ABC about me? It's those things that run through people's mind, and oftentimes a lot of people just refuse to go see a healthcare provider because they just would rather not deal with that. You know, it wasn't uncommon as a bartender. I had several patrons that would come to me for medical advice, or like, hey, I need help interpreting what my doctor said because they didn't explain it. I don't understand any of this. Or I would get calls in the middle of the night or text messages that one of the patrons ended up in the hospital, and I would go see them and help them navigate that, you know, tumultuous environment. And so it's more than just numbers. This is real life, and these people go through so much anxiety just to live. And so I think that's one of the biggest barriers.
What are the misconceptions or assumptions that create this environment that prevents LGBTQ plus folks from accessing care?
So I'll kick this off a little bit. I wish there was one single answer, but there is not. I think one of the biggest barriers is really individual bias, and one of the ways I think about this, and not to blame it on our training, but healthcare training, you learn to be a deductive reasoner, and you want to boil things down to their most simplest elements. And unfortunately, bias, both hidden and explicit bias, contribute to that thinking in a significant way. And so in our desire to come to a common denominator, we utilize a lot of stereotypical knowledge, as well as I mentioned, bias, which some of it we may not even be aware of, and make assumptions. And we use language to communicate those assumptions, which unfortunately lend to an environment that's not particularly welcoming. One term that gets used is heteronormativity. So there's the idea that everything is binary and it's heterosexually oriented. And even thinking back to when I learned about how to take a sexual history when I was in medical school, it was very gendered, it was binary, and it was not at all thoughtful of an expansive landscape of gender identity, gender fluidity, as well as assumptions as to who was having children and who didn't want to have children. So that, to me, that's one of the biggest roles in discrimination. And some of it, like I mentioned, is not even at the level of consciousness for providers.
Dr. Else, can you talk about how you as a physician work towards cultural competency and making your patients feel comfortable when receiving care?
So I think one of the major issues that we have when trying to figure out how to provide care to very specific communities is trying to get over our own pride of feeling like we have to know everything. So one of the first things that I will start with the patient is I will thank them for sharing their private details with me to make sure that they know that it's a comfortable environment. And if it's a topic that I'm not particularly well versed in, I'm just going to be humble and I'll start and I'll tell them, please feel free to educate me along the way if I use a wrong pronoun, or if there's something that I say that's offensive, because that's not what I'm meaning to be. I want this to be a partnership where we can communicate, and I'm here to learn and serve you. So I think you just have to get over your own pride and just know that you don't know everything. And I'm pretty sure that they're going to be more than happy to teach you their own side of the issues. Growing up in Oklahoma and being a gay male, it was hard to go to a physician. I don't actually think I ever brought it up to my my primary care provider. And when I went into family medicine, that wasn't necessarily my goal as far as being my main focus in my practice. But once I got out here, I noticed the significant need, and just being on the same level as the patient and making sure that they feel connected to you and they feel safe is the biggest thing you can do the entire time. You can try to have all the signs up in your office and have pride flags, which are great. It shows you're an ally, but it's just making them feel comfortable and thanking them for opening up and creating that relationship.
In AOF's 2021 OMED panel, our panelists also discussed creating a welcoming environment for patients for them to come out to their provider. Once those conversations happen, what specific health issues should physicians be aware of to specifically address issues that these patients may be more at risk for?
I'll start that off. I think as a sort of a stepping stone, certainly acknowledging that patients in the LGBTQ population suffer many of the same illnesses that someone who identifies as heterosexual. And so certainly some screening guidelines and stuff are fairly standard for those sort of issues. areas where there's a dramatic increased risk for illness in the LGBTQ population are mental health issues, behavioral health, and those are things that you know, in your primary care setting certainly should screen for those and ask questions. There are studies that support that adults in the LGBTQ community have 2 times a high rate of mental disorders, and transgendered patients have 4 times as much chance to suffer from mental health issues. So that's definitely an area of screening. And unfortunately, the pandemic seemed to bring that even more to light. Additionally, there are some groups, specifically lesbians and bisexual women, who may not have all the correct information around cervical cancer screening and those regular gynecologic care. And those are areas where certainly helping patients understand that they do have risks and may be at increased risks for some disease processes, specifically cervical cancer, so that screening is very important for them.
I definitely agree with what was just said. We have to take the same guidelines that we apply to everyone else and just make sure that we're updating them for our population. Another one that I like to point out was with the cervical cancer, we also have rectal cancer and HPV vaccinations that we need to be paying attention to as well. So when I was growing up, we didn't have the HPV vaccine for males at my age. And I can't tell you how many individuals come into my office that I really try to educate them on the availability of the HPV vaccine and how it can prevent certain diseases for both males and females. So that's a big one. Rectal cancer for gay men is also a very important one. So taking the same guidelines, exactly as you said, it's what we already know. We just have to re-examine those guidelines and see what has changed and make sure that we're paying attention and applying them appropriately.
And if I could add a little bit, some specifically around transgender health, certainly transgender men who have not had gender affirming surgery would need breast cancer screening according to their particular risk factors, if you will. And certainly if there's cervical tissue present, they need to have pap smears. And transgender women, their breast cancer screening really is based upon their age and for the length of time that they've been on any sort of hormones, because that does seem to increase their particular risks. Additionally, transgender women may be at increased risk for venous thrombolism disease processes. So again, screening them would be important. And one other, Dr. Else, I'll add to for the bisexual and gay men, domestic violence screening, which typically you may not think about intimate violence abuse in men, but definitely there seems to be higher rates of that, as well as eating disorders. Those would be two additional screenings that would be of benefit to those individuals.
And you mentioned some really important points, and it can be very uncomfortable as the provider trying to bring those topics up, because if these individuals are in transition, they may feel very uncomfortable talking about their breasts. They may not feel like that's part of their body. So you kind of have to approach the subject and, just say, try to say, this is a medical thing. I want to make sure that I'm approaching this without offending you. While we still have these organs, or while we still have these risks, we want to make sure that we're taking care of you. And you just kind of have to make sure that you have to approach it quickly, because it might shut them down pretty quickly if you come off offensive or kind of crude with talking about the organs that they may not even feel that are part of them.
Student Dr. Bolay, can you talk about how intersecting identities can also play a role in patient-centered care?
Well, yeah, so I think, I approach it this way. We live in a world that is largely based in ones and zeros, in the very binary system, where the further away you are from a cisgender white male, the more disparities you're going to encounter. I read this article is talking about white privilege versus Black Lives Matter and all of this, and it talked about the point of these movements is not to make you feel ashamed of being white or straight or living in a world that benefits you. You didn't ask to be born into that world to be who you are, just like we didn't ask to be born the way we are. It's more of you using that privilege that is inherent with who you are to then break it down from the inside, because us as outsiders, the furthest away, if you're Black, if you're gay, straight, transgender, or gay, straight, transgender, lesbian, any of that, you kind of don't have the access or the means in order to tackle the system, because everything is built in a way to oppose you. And I think if providers can come at with that perspective that this person is not going to trust the system that is not built for them, period. And don't be shocked if that person doesn't open up to you right away within the first 2, 3, 4, 5 sessions. It's going to take time for that trust to be built. So I think, and also understanding that even within, just the gay community, there's various different flavors. There's different cultures that exist within it. There's the Black culture. There's, we call them circuit queens. And there's a wide breadth. And so asking those questions like, hey, how do you identify what does you do on a daily basis? It's understanding where they're coming from in order to better treat them and then to better communicate with them.
So far, we focused on physician's role. What type of training or conversations should we have with staff and colleagues to achieve a truly welcoming, affirming environment that embraces diversity?
So some things that your staff and other sort of structural things that can be done in your office to help create a gender affirming environment, which I think speaks to Austin's point about developing the rapport and trust of your patient, include trainings that help staff understand culturally appropriate language. And there's a number of online training available, and not only asking staff to participate in the training, but then having opportunities to practice and develop a comfort, because I do think this takes a little bit of time and practice to do that. Additionally, to learn about your own hidden bias is a very helpful exercise, because until you have an awareness of it, it's difficult to change it. And there's the Harvard implicit assessment, which helps identify a number of different potentially hidden bias with some tests that you can do and get that feedback and some opportunity to grow and develop. So that's something you could do both yourself as well as encouraging your staff to do. Other things include development and use of forms that address gender identity, sexual orientation, partnership and family status, as well as providing patients a opportunity to write in other information. Those are a few things that you can do to help make your office more inclusive.
I do want to kind of step in and say something. One, I kind of hate the idea of like special training, because it gives the subtext that we're just these wild animals that aren't human, and it's kind of off-putting, and it makes you feel like I already can't trust that person. Oh, I need special training in order to deal with a human being. We are more than just being gay or lesbian or trans. We are also human beings surviving in a world that in many ways has gone into chaos over the past couple of years. But I do agree that, oftentimes it's kind of hard to say out loud a concern you may have and then being able to write it down. And then also being aware of microaggressions. A lot of times we say things and we don't realize that it is harmful. One of the things I have heard countless times when it comes to using pronouns is, I'll use your pronouns, but I just don't understand it. There's nothing to understand. It's, I'm asking you to respect me in a way that I'm respecting you by using yours, those are microaggressions that everyone needs to be aware of. And it's also, as the physician, we are leaders within our community, and that's the way that's the way it is. And so if you ever see a nursing staff or a front desk staff saying things like that, mentioning things like that, you need to stand up immediately and shut it down. I can't tell you again how many times I've witnessed staff members saying things, talking about patients in such derogatory way, especially HIV patients and things like that, that is outright wrong, and then the physician just not do anything about it, just because they don't want to cause a rift. That's got to stop. So yes, I guess it is training, but even starting at that word, I don't think you need training. I think you just need to be a decent human being.
We're talking about training practitioners, but I'm also interested in what schools and colleges of osteopathic medicine are doing to bridge the gap. Dr. Wadsworth, can you talk about what you're doing at your COM to specifically address this?
So that's a great question. And how are the schools, the osteopathic schools, training students or providing education to them? And certainly I can speak specifically to our institution and what we've done. So there are a number of ways. So we have educational opportunities that are called clinical practice reflections, and we invite patients who identify in multiple different ways to share their story with the students, give the students an opportunity to engage with these individuals, so to learn about those individuals and their experience with healthcare and ways to improve. So that's certainly one approach. The other very specific lectures geared towards specific health concerns as it relates to the LGBTQ populations, as well as we've taken on about a year of faculty development, because from my perspective, I felt that we would only really be successful if we spent some time with the faculty as well as the staff, providing opportunities for them to learn, explore, role play, if you will, because that, in my mind, helps create a culture of learning and exploring exploring in areas that maybe they hadn't otherwise. And then that lends itself to the ability to enrich our curriculum, not only with lectures, but in a more diversified way. And that maybe that's included in other learning opportunities that the faculty and the students are engaged in.
One thing as a medical student, one thing that I noticed, and Dr. Wadsworth brought this up, was organizing a kind of meet and greet where students of the campus were allowed to come, and we went to just a local establishment. And the goal of it was just to have a conversation with everybody. And the topic we chose was ask anybody who's within this community how they came out. What is their coming out story? And it was amazing to see. I had several of the cisgender heterosexual people that showed up say, I never knew that you went through that. I didn't know that was what it was like. I didn't realize that's how you felt. And there's just comments like that pouring in, and they had this new appreciation for where we come from, where LGBTQI plus members, why there's distrust and why there's so much anxiety when we're meeting new people, when we're stepping into a room. I can tell you, and I'm not the only one, that immediately when I step into a room, I immediately take a notice of my entire surroundings and make sure, am I in a place that I can feel safe, or do I need to have my guard up constantly? And that's just something that I know as a gay man, you just develop, because it is, I've been in places that have been dangerous and I've had to get out of. And so I think letting people hear those stories is vitally important, and it gives a perspective. I've found that people develop prejudice because they don't necessarily have a connection to it. And we're able to formulate this imagination that may or may not be real, but if they hear a story, an intimate story about someone's life experience, they tend to change that perspective. It's like, here's this person that I absolutely adore, And now I know this about them, and it just changes everything for me. Now, when I meet another person, I'm gonna, approach it in a different way. So I think that's, having just conversations, just ask, just talk. So immediately walking, into a space, oftentimes a lot of people who travel, and where I worked as a bartender, it was a very much a travel community, it was a tourist community. And every time they said they would just walk around the town and look for a pride flag. If they saw a pride flag, then they were a little more comfortable approaching that building and going into it and then looking. Another thing was just listening to conversations. You'd be shocked. A lot of people tend to not think that they're not being heard or being overheard by people next to them, but that is not the case. We hear everything. So if there's slurs being made, if there's, microaggression comments being made, I also take notice of, who is mostly in the room. If it's mostly these, cisgender heterosexual white men, I tend to be a little more hesitant. If there's a lot of women, it's just little things like that you kind of have to take notice of. It's also what city you're in. If I'm in a city up in New York, it's a little less off-putting than it is somewhere in Deep South, just because of political lines. And I hate that it comes down to that, but it truly does come down to that. And then also, it's just kind of a weird sixth sense that a person picks up, and they can kind of just feel the tension in the air. If you get all these weird looks because you happen to be wearing, jewelry or, clothing that maybe doesn't match your outward expression of gender, it's things like that you kind of take notice and inform you of what kind of space this is.
Let's switch gears and talk about what sets osteopathic medicine apart. What are the distinct ways in which the tenets of osteopathic medicine help prepare osteopathic physicians to care for members of marginalized communities, such as LGBTQ plus patients?
So I'll kick that off a little bit. I think by its very nature, osteopathic physicians, along with the philosophy of treating the whole person, starts to help us focus as to why I think this is important to osteopathic physicians and how we can contribute to the wellness. So because this is a marginalized group, because access to care, there are multiple barriers, as we talked about. And if we as osteopathic physicians hold ourselves accountable for the philosophy of the practice, then making sure we are aligned with taking care of a broad range of patients, inclusive of the LGBT community, really reflects our values and what we bring to the medical environment. Additionally, I think historically osteopathic physicians have been in the underserved or provided care in the underserved populations at a higher rate than other healthcare providers. And again, consistent with our philosophy of providing care where it's needed the most.
I know for me, when I was trying to decide, do I become an MD? Do I become a DO? And doing the initial research and trying to figure out exactly what the difference was, because it can be kind of muddy when you do all of that. And so what I came across was this, the philosophy of everything is interconnected, and we're not just, and I'll put this in perspective of like HIV patients. Oftentimes HIV patients are treated as a walking petri dish. They are just a viral count and a CD4 count. That's it. They're nothing beyond that. I think the National HIV and AIDS Initiative by the federal government finally released new guidelines that included quality of life measures. And you ask the question, why wasn't that involved from the very beginning? Before it was just CD4 count, it was just viral loads, and then taking medications, getting tested, and all that is very important. But mental health, the things that keep people adherent to those medications, to keep people going to the physician to get tested and for asking for preventative care, all that boils down to mental health, financial health, emotional health, and so that rung so well within me, and it I felt that this was, that core tenet, if that, that meant the most to me, it gave osteopathic physicians this unique perspective that, yes, everything is connected. I can't just treat this, I have to treat that person. I've had instances where friends of mine who are in the healthcare industry say, oh, I just can't get this patient to keep taking their medication. And then you ask the question is, well, have you asked them why they can't take the medication? Sometimes, and often it's, well, no. And then they find out, oh, they didn't have a ride to get it, or they don't have the money to pay for it, or, they don't understand how the medication works. And so they stop taking it and they don't understand why it's so important. And so it's all those little things that you kind of forget, but they're so vitally important to measure and to give this kind of comprehensive care to an individual.
Yeah, I believe osteopathic medicine, as we've already stated, is just founded on such a human basis, connecting with each other and creating that moment where you can have a relationship together that I just see across the board. So starting from school, we just learn that way to actually talk with the patient, lay our hands on the patient. I can't tell you how many people have said that they wouldn't even be touched, let alone acknowledged. So just by creating that relationship, I think is osteopathic medicine. It's where you're working together rather than telling the person what to do and dismissing them. So
What are some examples of how government policies or court decisions at the local, state, and federal level impact access to quality patient-centered care? And what are you seeing in your own communities?
I'll start this off actually with a personal experience. And so it's been now 22 years ago. My partner and I decided that we wanted to have kids. And we ultimately pursued fertility expert, and my partner had twin daughters. And shortly after their arrival, we moved to another part of the state. We were living in Ohio at the time. And because of state laws around and that did not allow for same-sex parents, we were sort of in a bind from the standpoint of being able to provide insurance for our girls. And because of the laws in the state at that time, my partner, who was their biologic parent, had to abdicate her parental rights to me because I couldn't adopt the children, so that I could provide healthcare insurance to them. And so as a result, I mean, as a parent, that's a big deal. That's a court-ordered position that she had absolutely no parental rights to her biologic children, just so we could provide insurance and that they could get the health care they needed. Now, I haven't followed the laws in Ohio recently, but I don't think they've changed. If anything, they've become more restrictive. I was grateful for the institution that I worked at the time. They did provide partner benefits sometime thereafter, and so we were able to have those benefits. But that's a very personal experience that I had around state law.
a lot of the concern that I have going forward would be a lot of the laws that are being introduced in the South as far as transgendered care and PrEP access are two of the big ones down in my area. And it's an evolving moment. I don't know where it's going to go. I'm worrying that it's heading the wrong direction, and it's concerning because it's hard enough in Oklahoma to find a provider, but then to have some of these patients have to go out of state to get some of their treatments or some of their needs met is mind-boggling. I don't know how it's going to work. So I'm praying that the issue kind of stalls and we're able to continue providing hormone therapy and PrEP access to patients, because if we aren't, we could be in some serious trouble.
I'm glad you Dr. Elsie brought up, PrEP access and all of this stuff. One of the biggest things in this country that's kind of, I think, is kind of the biggest contributor to the overall stigma that a lot of LGBT, especially gay men, experience when HIV treatment is HIV criminalization. Right now, in majority of states, you can be criminally charged if you do not disclose your status to someone, which does, and the evidence shows this, it does absolutely nothing but contribute to the stigma. People then do not get tested because if they don't know, they can't be charged. They don't reach out for PrEP access, and they're afraid to have conversations. Just to give a personal experience that I'm currently dealing with now, on social media apps, I have gay men reaching out like, I don't know how to ask for PrEP. I don't know where to go to get it. I don't know how to ask another person what their status is. I don't know if I should go get tested. Should I go get tested? And it's just all these questions that they're out there and they want to ask, but they're afraid to ask, or they don't know where to go to ask. And another thing, they don't know if their insurance will cover it. They don't know if their provider will even give it to them. And then some people just don't even know that it exists, which boggles my mind, but it does exist. They have questions about that. And so I think HIV criminalization needs to be reformed. It's just, and hopefully get rid of that, to then get rid of the stigma, so then we're able to have this open conversation about it, because modern medicine has come so far since the 80s when the AIDS epidemic hit. And with modern medicine, especially with the CDC releasing the U equals U, HIV people can live completely normal lives as if they were HIV negative and have partners and live a normal life. And that's not being talked about enough. Instead, it's, I don't want to get thrown in jail or, ostracized because I happen to just have this disease. And I tell people all the time, it's like, it's bad, but there are diseases out there that are far worse. Diabetes is one of them. And so I think that's one of the biggest things when it comes to political stuff.
And hopefully, we're in this discussion and we should have clarified this earlier, but PrEP is pre-exposure prophylaxis, PEP is post-exposure prophylaxis, and then U equals U is undetectable, is untransmittable. So.
Dr. Wadsworth mentioned the Harvard assessment tool that can be used to assess your own implicit biases. Are there other resources that you'd recommend we provide to our attendees today to continue their learning after this session?
Yeah, the GLMA was one that is a great locator for finding providers and even just information. I think there's also we were just talking about the PrEP, but just preplocator.com I think is one. But if we can tell the providers that using the GLMA is, you can get resources there, but you can even just get on there, getting your name in that directory of providers that will let you search and find someone in your area. And you can say what you are trained in and what you feel comfortable treating. Just having that access out there is really important. So that's a big one.
This is not like I think, it's great to have these national websites and databases to learn about kind of what the risk factors are, get the statistics and all of that. But it ultimately is going to boil down to you communicating with your local community. Get in touch with your local pride leaders, get in touch with the local bartenders. Often those are the leaders of the community. Get in touch with anybody and everybody that's part of that local community, because they're going to know it the best. If you can get in with them and let them know, make that first move that, hey, I'm here, I want to help, I want to learn, all of a sudden you're going to have access to this community that you normally would not have. And so that, I think that is probably the best resource you're ever going to get as far as treating your local LGBTQIA+ community, is reaching out to the leaders of that community and establishing that relationship and making sure you stand by your word.
Definitely second that. And I think it's a bi-directional relationship. If you put your name out there and let them know that you're willing to provide care to those individuals, you also need them, because there's going to be times in your practice where the patient can't afford the care and they need the resources on the local level, or they got kicked out of their house and there's a local organization that can help them find shelter for a little bit. So you need, by getting that relationship established, you can reach out quickly in scenarios that you have no idea what to do, because there are a lot of them. And those individuals, like we have an Oklahoma Equality Center, I reach out to them all the time because there are a lot of circumstances that I just wasn't prepared to help with, but the patient trusted that information with me, and I wanted to make sure that I didn't let them down. So you're not supposed to know everything. Use your resources, and the local ones are great.
Absolutely, I would certainly echo that. Some other more national or even world resources that are available, and online is the World Professional Association for Transgender Health, so WPATH. That's a great resource specifically around transgender health. University of California, San Francisco has a really rich website that can provide all kinds of information. And again, specifically around transgender health, guidelines from the Endocrine Society is another good resource for practitioners to use just to inform themselves or even to help guide patients or provide treatment to patients.
And I do want to say, we talked about interacting with the gay community and having those uncomfortable conversations. I imagine there's a lot of anxiety because you don't want to say the wrong thing. A great place to start is to read books. There are several books, LGBTQIA+ books, that go into detail about, that writer's experience with coming out to their family, and it comes from all different cultures. One book in particular I thought really stood out was Tell Me How to Be by Neil Patel. It deals with both the intersectionality between culture, race, and being LGBTQIA+. It's a fantastic book to kind of give you an insight to what goes through a person's mind when they're dealing with their own sexual and gender identity. And not only that, their internal turmoil, but dealing with their family and the culture that they're growing up in, and sometimes even their religious affiliations. Another one is Giovanni's Room by James Baldwin. He's a very well-known writer and novelist. So, those are great resources to use. It's a way for you to kind of, get your foot in the door and get a little more comfortable with hearing these phrases or terms or whatever. So don't be afraid to start there.
For my final question today, I want us to think about the future. Despite the challenges we face in protecting the health of the LGBTQIA+ community, can you share something positive you've seen or experienced that makes you hopeful for the future?
I'll kick this off, and what a great way to end. So there's hope. I absolutely believe this, and the one thing that makes me really incredibly hopeful is something that my kids taught me, and they've been my very best teachers. And as I mentioned, they're in their early 20s, and for them and their peer group, gender fluidity, diversity is just part of who they are and what they expect. And so I think because of that generation and what their expectations are and how they behave, I think they're going to push, particularly us old folks, into the right direction. They're going to demand that we are much more inclusive, that we educate ourselves and create an environment that is as inclusive as we possibly can make it.
Dr. Wadsworth, I think you said it the best. The hope that comes from the fact that our culture largely is starting to embrace this gender fluidity and embracing people's sexual identity. With drag queens becoming mainstream, and that culture is getting out there, is kind of the hope that things will follow. And then another thing, just the fact that of me being here and being allowed to sit at the table and to have this discussion, to share my point of view, it means a lot, because a lot of times I know with young people, they don't feel like they have a voice or they're allowed to have a voice. And so just being allowed to have this kind of platform it means a lot, and kind of gives that hope for the future.
I agree. I mean, it's pretty amazing that this type of discussion is being had. I don't think it should be surprising, but it is. So that's a great one. Another great thing that I'm seeing too, one of the things that I'm involved with is medical informatics, and we're seeing a big shift in the technology as well for EMRs. And I encourage you to look and see what your EMR is and whether they have the features that would allow you to provide better care to this population. For example, Epic is one of the ones that I'm working with, and they allow you to change your patient's preferred name on their chart. So when you're sending to the pharmacy, it'll still legally go with what they need to, but when you're addressing them and calling from the lobby and you're printing stuff out, it has their preferred name, and that's a big deal. It has their preferred gender identity, and until it's legally changed, yeah, that'll stay in the chart the way that we need it to be medically. But it also will help you in a sense that you can put in whether they were born male or female, and whether they have had certain surgeries, and it will remind you of all the health maintenance that you may accidentally overlook. So if your EMR doesn't have that, I would talk with your administration and see if that's a feature that you can request. Or maybe talk with your administration about getting a better, more inclusive EMR for your patients. It does make a big difference, and it's really cool to see that being acknowledged. And it seems so simple, but it can really make someone feel a lot more comfortable. I mean, I think that's probably the biggest one. Obviously, we have telehealth now, so we got forced into that. And that, if you can accept people, if you only have a state license, then if you're able to accept people within your own state and find a way to reach out to the smaller communities, like for instance in Oklahoma, I don't even know how far. I've had people drive like 3 or 4 hours to see me in person, and then I can continue, especially mental health. Like that's one that's so easy to do over telehealth, to get to those smaller communities. So I would try to start finding a way to maybe reach out to other communities in the area, and getting your name out there to do telehealth, and reach those areas as well.
Finally, I'd like to ask each of you to please close out the session with your final thoughts and what you hope viewers learned from our training today.
As we come to a close, I want to again thank Dr. Grove, the American Osteopathic Foundation, and the American Osteopathic Association for being thoughtful and providing this kind of opportunity to both, share personal experiences as well as what the future will look like as we move forward to provide comprehensive, person-centered care that ultimately improves the health and well-being of our patients, as well as those in our region, and maybe one day even more than that. So I am hopeful for the future. I'm grateful for medical students who really push the boundaries at times and help us see a brighter future.
I really, really appreciate the opportunity to be here with the AOA and the Osteopathic Foundation as well. It's something where, as I said earlier, I never would have expected to be a part of this. And so the fact that we're here and we're getting to do this, and we have a great audience and people interested is very encouraging. And I know there's multiple osteopathic colleges that are working on legislations and trying to find ways to be more inclusive. So if you don't feel like you're in that spot to be able to write those, if you can provide support and just do anything you can to help the community, it's a pretty big deal, and it means a lot. And then lastly, as I said before, it's really important to know that as an LGBTQIA patient, we just want to be accepted and feel comfortable. So it comes down to letting go of your pride and being humble and making that connection, making sure that you make them feel comfortable so that they can open up to you. It's an amazing experience to see some of the people just let go of their breath and just stop holding it, just open up and know that they're in a safe environment. And I appreciate everyone coming in and listening. Hopefully we continue to have these seminars. I know I've learned a lot. It seems like we're supposed to know everything about this, but we've had such good comments that I'm really thrilled to even have been on the panel and learn even more about what else can be done.
Yes, and I specifically want to, thank the AOF, AOA, and Dr. Grove for just giving, people like me a voice. Oftentimes medical students feel like they aren't allowed to have a voice because if we voice our opinion, then it can, impact our future career choices and things like that. So just being able to sit at the table and, say how we're feeling, to embody, all of the feelings that we are, having to bottle up all the time, it truly is a good step in the right direction for making this more of a discussion rather than a dictatorship. So again, I can't say enough how thankful I am that this opportunity is here. And I truly hope that the discussion doesn't end here. I hope people go home and continue to have these discussions with their peers, with their own medical students, with their own professors, their own community members. This, discussion should never stop. So that's my hope for the rest of this.
Thank you all for joining the American Osteopathic Foundation for this second session in our health and wellness training. Sincere thanks to our panelists for spending their time and expertise today. This session is being presented in concert with OMED 22 and will be available on demand on the AOA online learning platform. Additionally, it will be posted on the American Osteopathic Foundation website at no cost to the viewer.